Assalamu alaikum, good evening. This is Dr. Asiry. Today I will provide you with a clinical scenario about a hand burn. So this is a case that can definitely come up in the exam, and I would like to talk about it in a way that can help all future candidates who are set up for the exam to be able to answer the case effectively and get into a proper description of the case from the beginning to the end. All these information that are provided are not only they are definitely helpful for the exam, but they are as well helpful for clinicians who are general clinicians who may face a burned hand, what they should do in the acute phase. It is helpful as well for physiotherapists how to handle it after they are healed. So all of these information can be helpful for lots of you guys. So thank you for the support. I have got an amazing amount of messages and positive replies. So we will go with the scenario. This is an imaginary patient. You have a patient that he has both of his hands burned. This patient is 47 years old. And how would you start with this case? So I already have my notes, so I will go with them over my notes, and then it will be more interactive. So in that case, what you should always remember that when you have a case, you will say this is a clinical photograph of a patient. This is a clinical photograph of a patient who presented with a bilateral hand burn with a varying degree. My initial assessment, this can be either first degree, second degree, or third degree, and it's better that you get into a more detailed assessment of saying this is a superficial, partial, deep partial, or full thickness burn. You would say that my initial assessment will be to stabilize the patient and follow and take the patient through and care for the patient through an ATLS protocol, and then you conduct a focused history and physical examination, and you will conduct an ample history. Ample history is an allergy, medication, past medical history, and a last meal. This is an ample history. It's better that you always ask about mention these in the exams. Examiners love it. And you should say that you will start your treatment for a burned hand is stabilizing the general condition, avoiding making sure that the patient doesn't have stabilizing the airway, especially the airway in the acute burns are very important. The hand are the functional ones. So hydration preventions, you will go when you go to the hand directly, you will go hydration preventions, hand elevations, antioxidant supplementation can be supplementation. Ensuring the vascularity of the hand is very important, especially in acute setting, and that is why you always have to follow the signs of a compression of the hand, and that signs of compression, pain, pallor. They are in pain. They have pallor, but pain on a passive extension is one of them. And the most important thing with the burn is a tender, tense skin, and for that you will do an ischorotomy. And the ischorotomy of the hand, the lines of the ischorotomy, I can just show it for between the first and second metacarpal. You do 2 lines, and rarely that you can find that someone do the fingers. But if you do the fingers, you have to do only one side, never two sides together. So then you have to know that in the hand there are 10 compartments as well. There are the thenar, the hypothenar compartments, the interosseous compartments as well. So incision of the lateral and dorsal sides of the fingers can be performed, and a carpal tunnel opening in severe edema can be one of the things that we can do. In superficial burns, my initial assessment will be with the cover with a sulfur sulfadiazine cream for a 24 hours, then hydrofiber or hydrocellular dressing and then I will maintain the dressings protocol for 10 to 12 days, and then I would change the superficial layer in the frequency of 2 to 3 days. Various protocol, various dressings, but this is what we usually do. When we talk about the surgery, we are with the school of an early debridement and skin grafting. Early debridement, which is defined early debridement or early excision, which means that you excise the burn within the first 8 days, and then the late grafting, which means that after 15 days. So either after in the first 8 days we call it excision and grafting. After 15 days to 21 days, this is we call it an late excision and grafting. So use a laser Doppler evaluation for a surgical decision. We usually don't, and mostly it's a surgical experience. Superficial burn, that they come with the redness. Deep superficial partial, they have the hair attached, but they don't have a good capillary refill, and they still have pain. When you go for the deep partial thickness, you can take out the hair follicles. When it comes to the 3rd degree full thickness, it's leathery, it is hard, and that's a full thickness burn, and the only solution for it is to be excised. When you go for the early debridement, you have to preserve the living tissues as much as you can. Try to preserve the paratendons, and then the choice of a grafting will be covering it with a thin unmeshed graft, sealed. You can seal it with fibrin glue, or you can seal it with an occlusive dressing in that case. You can mention that in your post-operative rehabilitation. In early rehabilitation, you will start active and passive mobilization after the first dressing placement. Between the 3rd and the 5th post-op day, to prevent pain during a treatment, and you lose elastic non-adhesive rubber bandages. And a nighttime splinting is very important. The nighttime splinting is the safe position. The safe position, it will be an extension of the wrist and a flexion of the MCP joint to 70 to 90 degree with an abduction of the first web space. This is the safe position. It's very important that you do it for the burn patients, and earlier the better, before the edema take place, and it will be difficult to immobilize them in that position. In a long-term rehabilitation, you will use the compression there is a compression gloves, and that compression gloves, they have to go beyond the capillary refill pressure, which means it has to exceed the 15 millimeter mercury. This is the pressure that these compressive garment has to have it. They have to go beyond that to induce a local hypoxemia, and in that case it will prevent the hypertrophic scar. So when we go with the long-term rehabilitation, you have to mention that you will engage the physiotherapy and functional therapy. You will do your reconstruction and you'll do your reconstruction and coverage with a deep structure. You will consider dermal substitute if there is an exposed tendons, and sometime you will do 2-stage reconstruction. It depends on the defect. Expected outcome, always you have to achieve good function outcome and a pleasant cosmetic appearance. Lastly, you have to mention if there is a loss of tendons, that you will start with the soft tissue first, then you will start the tendons. You have to mention the use of dermal substitutes like Integra, or the use of another dermal substitute like Metriderm. For choice of a free flaps for the dorsum of the hand, we talk about dorsum of the hand. We can talk about the use of a free flap like a temporalis fascia flap, and we can talk about the use of abdominal flap, of inguinal flap. choice of a free flap in burn, mostly some people don't like it, and some surgeons don't like it, either because of the experience, either because the experience of the surgeon plays a role. Another one is the hypercoagulable state that is associated with the burn patient. Be organized during your exam. Give all of these options. Give all of these structures. If you are going to use a flap as a free flap, mention the reasons. Mention the way that you are going to do your flap. Mention the steps of how you do your flaps, and be aware how you do the marking, because some of the examiners can ask you to do the marking on a paper, so they are sure that you know how to do it. Thank you for following me. I hope that was beneficial. This is Dr. Asiry. Keep following me, and I'm waiting for your feedback. Thank you very much.